You can see the slide here. That's the plan for the evening. There's a chance that Dr. Antony might still be in the OR, so if we can't hear her talk, which we'll be disappointed about, but we'll have a little extra time for questions at the end. All right, so we'll go ahead and get started. It looks like we got a nice group here with us. Thanks again for being here with us for the PSRC Best in Breast mini sessions. This is session 3 of 4, and our last session will be Thursday evening when we get to hear the second round of best breast abstracts from accepted to PSRC. So I hope you can join us then at 8. Again, thank you to Jason and to Allergan Aesthetics for sponsoring these sessions, and we really appreciate your support of the Plastic Surgery Research Council. So we'll just go ahead and dive in with Dr. Weichman, and then we'll have Dr. Schwartz. I'll speak briefly, and then Dr. Antony. And Dr. Weichman is an assistant professor of surgery at the Albert Einstein School of Medicine, Montefiore. She is the director of breast reconstruction services there and has research interests in health services research, specifically with patient-reported outcomes and quality of life and informed decision-making. And she's going to speak to us tonight about breast reconstruction in underrepresented minority patients. Dr. Weichman?
Hi, thank you so much for having me and for all those that are attending the session. I'm just going to speak about the challenges to performing breast reconstruction in underserved minority populations based on managing outcomes, managing expectations, and optimizing outcomes. So just first, what is an underserved population? So medically underserved population, or MUP, or a medically underserved area, MUA, is a designation given to specific areas and population where there are too few primary care providers, high levels of poverty, high elderly populations, and high infant mortality. To reach the designation of an MUP, you have to have an index of medical underservice less than 62. And what the index of medical underservice is made of 4 criteria. So there is a provider per 100,000 population ratio, the percent of the population at 100% of the federal poverty line. And just for a reference, the federal poverty line is for a family of 4, 26,200. That is what the poverty line is. The percent of the population at age 65 or over, and the infant mortality rate. And the score is out of 100. So if you are less than 62, you are a medically underserved population. So my population is here in the Bronx. I work at Montefiore, and we serve mostly the Bronx, as I've circled here, in Upper Manhattan. And next to the map, you can see the map of medically underserved populations, and you can see that it is a majority of blue in the population that I serve. So to sort of isolate the population that we're dealing with, I'm just going to look at my patient demographics that I perform breast reconstruction on. So the language spoken, only 46% speak English. So 54% of patients speak either Spanish or other language. So we're dealing with interpreters very frequently. I'm going to talk about ethnicity and not race because I think it makes it a little more clear. So the majority of my patients are not white. So 43% of patients are Black, 45% are Hispanic non-white, and only 6% are white, 3% Asian, and 4% other. So it's a majority non-white population, which is different from most of the plastic surgery literature and representation that we see. Looking at the income of my patients, so 75% of the patients make under $40,000 a year, and 50% make under $20,000 a year, which is quite shocking statistics. And then looking at the education level, so the majority of the patients either have had only some high school or high school graduate. Only a little over 30% have had college or master's degrees. And then finally, looking at the cancer stage on presentation, which I actually had initially thought was a more advanced presentation, but when looking at the data granularly, it looks like it's pretty in line. about a quarter of patients present with DCIS, about a third of patients with stage 1, and then stage 3, 2, and 3 making up another 40% of the patients. So these are the factors that I think sort of make it difficult to deal and service these patients. So this is just a schematic of a general consult. You see me over here, the telephone, the patient who's going to be undergoing breast reconstruction with many distractions, often a child in the room, a telephone going off, and here I am trying to have a sort of systematic discussion with them, trying to decide if they're going to have implant, if they're going to have autologous reconstruction, what are the risks, what are the benefits, what do they want, what do I want, how to manage all of these things is particularly challenging with these limitations. So what I see as the challenges are basically performing shared decision making, which there's a lot of evidence that is important in patients having high satisfaction and overall better outcomes. And I think because of the literacy, numeracy, and English fluency in dealing with my population, it presents a significant challenge. The cultural norms that my patient population represents and desires is not always in line with what I want, and I find that also challenging. And then the high incidence of medical comorbidities, including obesity, presents significant challenges to dealing with this patient population. So in order to deal with these challenges, these are just some of the ways that I try to help improve my outcomes. So I'm looking at it in two ways: preoperative interventions and intraoperative intervention. So preoperatively, we're going to talk a little bit about using a risk assessment calculator, using decision aids, the use of photographs in order to sort of really clearly show patients what they can and cannot expect, and then the use of more than one appointment in preoperative consultations. I think it really needs a lot of time to sink in, and then how to accurately manage expectations. So the risk assessment calculator, this is what's called the BRA score, and I find it pretty helpful. I have not yet, but plan to validate it in my patient population. It's a tool that was developed out of, I think, Dr. Kim out of Northwestern, and it takes in some patient information and to try to assess your risk. And I'm going to show you an example of what you get. So here's a patient example. So a 62-year-old, BMI of 37, former smoker, diabetic, hypertensive, prior chemotherapy, who's undergoing bilateral reconstruction with no radiation. You put all that information into the calculator and it will give you this sort of score sheet, giving you the overall surgical complications associated with tissue expanders, flat pedicle trams, latissimus, and microsurgical anastomosis. So you can look at this as a provider and say, is this a risk that I'm willing to take, and relay it to the patient? I think it's difficult sometimes to relay these risks to the patients as sort of odds and percentages, as Claire-Lee has often pointed out, are difficult to translate in. So another way is to use decision aid. So this is a decision aid out of Stanford. It was the first decision aid that was sort of shown in the literature, and it's a simple tool that tries to improve outcomes. I do not use this one. There is another tool that's out there that they just published in February out of Washington and St. Louis. It's called the Breast Choice Tool, and I think it's unique in that it uses this BRA score within its to give you an icon array of your risk, and patients can do it online and interactive. And they showed to improve decision quality, reduce decisional regret, improve knowledge, and it gives you that individualized risk assessment to the patient. For my population, I didn't think that this is appropriate. So I have worked to develop this picture option grid with collaborators in Dartmouth. And it's, as you see here, in English and Spanish, and it's very simple pictures with very simple instructions. And I think it uses frequently asked questions and tabs to sort of delineate the common questions that patients will have, and they can go home with this. In our pilot study, we showed that they improved satisfaction with information, improved decisional regret, but they did not have any improvement on the knowledge metrics. And I have been kicking myself about it for a while, and I think that unfortunately, maybe that is not important for this patient population to have knowledge, rather be okay with their decision, because they have an aversion to tests, and even doing the studies and the quizzes gives them intense anxiety. Additionally, photographs. So I think managing expectations on results, what you can expect. So here is an example of one of my patients. She had extremely ptotic breasts before. She has very long scars, but I think an acceptable result. But some patients would see that and say that's not acceptable to them. And I could then try and tell them that this is the best I can do and this is what you should expect. And this is another patient who had bilateral reconstruction with free flaps and with nipple reconstructions. And I think she has an acceptable result also, but I think it's important for patients to realize what they can expect. This is another patient that is coming up for my in one of my cases, and I think she's just a sort of a case study in how to manage the expectations. So I try to give the worst case scenarios, show all of the scars that would be possible, highlight that multiple operations will be required, and that you'll never be completely normal or symmetric. And then that the most important thing is to treat the breast cancer. I think leading with all of these things is highly important to sort of have them not upset with you at the end. I think my tendency at the beginning of practice was try to promise a lot, but now I try not to promise so much. And finally, interoperative. I think these are probably no different than what anyone else does, but I think mastectomy skin flap quality is of the importance in your decision making, and using SPY and techniques to mitigate donor site complications is important for outcomes. So if using the SPY and making the decision tree and telling the patients that you may only give them delayed reconstruction. And I used to think that that was sort of a bailout, but now I think it lays the onus on the rest of the treatment care team to sort of take responsibility for their impact on the patient's life. And then I use techniques sort of developed and highlighted by Dr. Teosha and Haddock out of UT Southwestern, that in these obese patients undergoing free flap reconstruction, mitigating donor site complications is really important. So I do umbilicectomy if their stalk is greater than 4 centimeters, and limited undermining and trimming the subserpal fat sort of to decrease the donor site complications that can be treacherous. In conclusion, I think there's complex decision making that goes into breast reconstruction. It is extremely time consuming to discuss this with patients, especially in underserved populations, to match their expectations to your expectations. Decision aids help, photographs may help, and I think managing expectations is one of the most difficult parts of starting your practice in dealing with plastic surgery patients. Just want to say thank you for tuning in, and I appreciate being included in the panel. Thank you.
Thank you so much, Dr. Weichman. It was great to hear you talk, and it's really excellent advice that you give at the end about what can be a very difficult conversation with patients. We're going to have time for questions for everyone at the end, so we're going to move on to Dr. Schwartz. He is someone that I'm proud to say is another former resident of mine, and so a graduate of the Cornell Columbia Plastic Surgery Program, who then did microsurgery fellowship at Memorial. He's currently the director of microsurgery and breast reconstruction fellowship at Cleveland Clinic, and is the co-director of the Multidisciplinary Center for Lymphedema Care. And today he's going to speak on approach to lymphedema and prevention. Dr. Schwartz.
Thank you. I'm just trying to get the my screen share to work here. I think I got it. Okay. All right. I just want to, I want to sort of apologize in advance because my internet, I keep getting these unstable internet advisories on my computer screen. So if I cut out, apologies. That being said, I really want to thank the PSRC and specifically Christine for inviting me to be part of this webinar series. It's really been terrific to see all the various presentations and the scientific sessions, and it's a great platform, I think. So thanks for doing this and including me. So Today I'm going to talk a little bit about immediate lymphatic reconstruction and some strategies for preventing lymphedema in the breast cancer patient. And I hope that today I can help you get started to incorporate this type of approach in your practice. And many of you may already do this. For those of you who do, maybe we can just stimulate a little bit of conversation about it. So lymphedema is a critical problem, and it affects millions of people worldwide. And in developed countries, most commonly, it's a result of various cancer treatments. And it's widely regarded as an incurable condition that, that may change. There's some treatments that have been emerging, both from a medical standpoint and the surgery standpoint. There's really long-term health implications related to lymphedema. It impacts patients' function, it impacts their self-image, their quality of life, and really it exacts a real economic burden on the patient and the healthcare system overall. So what I like to do is talk about some risk factors for the development of lymphedema, some surgical tools for mitigation of the development of lymphedema, talking a little bit about some of the history behind this and existing data. We'll talk a little bit about different techniques and some refinements. We'll talk a little bit about our institutional experience and starting collaborations, and a little bit about surveillance. So risk factors for lymphedema in cancer, there are a number. Primarily, lymphadenectomy serves as the major, risk factor. This can be in any anatomic location, axillary, inguinal, pelvic. There's been really a trend toward lymph node sparing surgery in the last number of years, but even in sentinel lymph node biopsy, there's still a 4 to 6% chance of development of lymphedema alone. Radiotherapy, postoperative complications, certainly increased BMI, and certain chemotherapeutics, including taxane, are known risk factors. And the rate or prevalence of lymphedema in breast cancer patients seems to vary depending on the study you read, but on average, maybe about 30% of patients with breast cancer treatment develop lymphedema at some point in their life, and about 3/4 of these patients will develop this lymphedema within 3 years of their diagnosis. Obviously, other cancers confer a risk, and it's highly dependent on the treatments that patients undergo as a result of the cancer diagnosis. So the mainstays of lymphedema treatment have really been physiotherapy, compression, complex decongestive therapy, which is kind of a combination of manual lymphatic drainage and compression. But these treatments are cumbersome, they're time consuming, they can be costly to the patient in terms of fitting and refitting and buying garments. We've kind of migrated to, well, maybe we can help these patients with surgery, and certainly some of these treatments are promising. They run the gamut from volume reduction procedures to physiologic procedures like lymph tissue transfers and lymphatic venous bypass, or even staging and combining these treatments that holds some promise. But really, maybe we should be thinking about prevention. Maybe that really is the direction we should be headed. And that can mean a number of things at a number of different places. It can range from doing absolutely nothing in some places to having some minor education about activity limitations, maybe wearing a compression sleeve from time to time. I think combining a surveillance approach with an education approach, I think is really probably the gold standard, and maybe even incorporating different sort of more objective measures such as bioimpedance spectroscopy and volumetric measurements. There are some surgical tools that we can employ as well. Reverse lymphatic mapping is one of them. I think this was popularized by Dr. Klimberg in breast cancer. And essentially what we're doing here is we're injecting a tracer into the extremity. We're really trying to delineate the lymphatic pathways in effort to potentially preserve some pathways in continuity. And this has been shown to be promising, and there's been a reduction using this technique alone in lymphedema rates. This can lead to sort of a false sense of security because, in, for example, the axilla, this is a crossroads between lymphatic drainage of the breast and the upper extremity. And if you choose to, avoid the sort of blue stained ARM nodes, this can lead to under-resection and incomplete oncologic treatment, especially in patients with advanced stage disease. So this potential to under-resect is real. So as plastic and reconstructive surgeons, we have the technique of lymphatic venous bypass, which we can use to reconstruct the lymphatic system. And in the immediate setting, what we're attempting to do is restore anterograde lymphatic flow. But there can be some technical challenges associated with this. It can require super microsurgery in some cases, and the exposure, especially in the axilla, if it's a larger patient, deep in the axilla, can be somewhat challenging. It's not an entirely new concept to do this type of approach prophylactically. Back in the 80s, a Soviet surgeon described using lymphatic venous bypass in the cubital region at the time of mastectomy. But really, as we know it today, I think the group out of Italy in Genoa, Dr. Riccardo and his team described the approach lympha. And basically, when I say immediate lymphatic reconstruction, I'm referring to lympha. I think that the term immediate lymphatic reconstruction is quite frankly what we should be, sort of converting to, because I think it describes what we do, and that's credited to the Beth Israel group, I think, for coining that term. I think it's a very accurate and a good term for us to use moving forward. Other members of this panel, i.e. Dr. Rohde, has some experience with this technique and published their experience at Columbia, which showed, I think, some promising results, and systematic reviews also kind of have backed this up. But I do think we need to have a healthy skepticism. A lot of these studies have limited sample size and follow-up is limited. And, the impact of various cancer treatments is a little bit difficult to discern on the incidence of lymphedema. Some recent results are even equivocal. I think, though, if we can demonstrate that, in fact, this works, then I think we can, clearly see that it adds value. And there have been cost utility analysis that have been done that show this as well. So, we at my institution have taken some of these experiences and adapted them and refined a little bit of the techniques, and we've kind of put them to use both in the breast cancer realm and in the melanoma realm with Dr. Gassman and our various breast surgical oncologists, and a lot of my plastic surgery colleagues. And so, the principles are that we use axillary reverse mapping to visualize and preserve lymphatics when possible. We modify our tracer injection a little bit to make sure that we get good, coverage of the tracer dye through all the lymphatic pathways. One critical thing is we've encouraged successfully our breast oncologic surgeons to perform their axillary lymph node dissections under loop magnification. So they do it in a little bit more of a refined way, and they're able to maintain more in continuity lymphatics. They're able to visualize and mark transected lymphatics a little easier, and really critically is they're able to handle the venous recipient branches much better. They clip them, they don't burn them. It makes our lives a lot easier, and I think this whole thing a lot more effective. Then we come in, we assess the architecture of the axilla. We can perform lymphatic venous bypass, in sort of a modified or an algorithmic kind of approach, depending on the architecture of the veins and where the transected lymphatics are. So I think one major thing, if you're going to embark on this, or if you're doing it and you're trying to make it more successful, is you really should work in tandem with your breast surgeon to really design incisional placement. I think you can make your life a lot easier in terms of the exposure in order to perform the LV bypass if you do it this way. Extend your incisions as needed up into the axilla. If you are performing breast reconstruction in tandem with this approach, I recommend that you do the all of your microsurgery or super microsurgery before you put the implant actually in place. But before you even do that, you can construct your pocket and have that ready to go. So when you're done with your ILR, you can go ahead and put your implant in. So take a look at the architecture, try to make sure that the continuity of the lymphatics that are already preserved stay preserved, and really plan your retraction. I think that, operating in the axilla is something that older, I think, more seasoned plastic surgeons have done in the past when they do microsurgery. I think for younger plastic surgeons who are doing microsurgery, they're maybe less used to this recipient site. So anyone who's done it, especially if you're assisting, knows that you're kind of like hanging on a trapeze sometimes when you're trying to do work in this area. So making your life easier is really critical. So when you look at the axilla, you want to assess the lymphatics. You need to make sure your field is dry. You can always massage the upper extremity to dilate the lymphatics. And typically, from an anatomic perspective, at the caudal aspect of the axillary crease, kind of where the upper extremity meets the axilla, is where you typically find most of your candidate lymphatics. You can use not only blue dye, but you can use other fluorophores. Actually, you can even fluoresce your blue dye if you have the appropriate wavelength to excite it. And that sometimes helps you find more. If you see open lymphatics, clip them just to dilate them, makes it easier to work with. Perform minimal lymphatic dissection, quite frankly. You should, I think that in my experience, performing more venous dissection allows for greater excursion, allows you to get more lymphatics kind of hooked up. I think the vein is really the rate limiting step and arguably the most important part of this procedure. You need to ensure that you have appropriate length and good excursion. You need to check the backflow, make sure that you have valvular competence and not too much backflow to overwhelm the pressure of lymphatic drainage. So, again, looking at the architecture, you can decide based on the size of the lymphatics and based on the number of lymphatics and the size of the veins. Are you going to do an intussusception technique or so-called octopus technique, or are you going to do an end-to-end or end-to-side? And all these things just are situational and dependent on what you see when you get there. So, this is an example of a 3-in-1 sort of intussusception technique. And this is similar to what was originally described with the lympha approach, but we're really truly using sort of a super microsurgical approach here with 11-0. Sometimes if you can get lucky and have really large vessels and maybe use 10-0 microsuture. But sometimes things are really small and you have to actually go to super micro in order to achieve what you want to do. So, once you're done with that, make sure you confirm your patency. You can do that with blue dye. You can do that with ICG lymphangiography. Usually we like to confirm it with these two methods. Typically we'll perform a baseline lymphogram at the time. So that serves two purposes. We get a baseline of the lymphatic function of the upper extremity, and we can follow it up through our anastomosis and confirm patency. So when we've looked at our series over the last 3.5 years or 3.25 years, we have a prospective registry, and we looked at our study group up until about this past February, which consists of about 106 patients. We compared it to a control group who had only axillary lymphadenectomy as opposed to axillary lymphadenectomy with ILR. We looked at clinical outcomes, including clinical indicators of lymphedema, arm circumference, bioimpedance spectroscopy in a number of patients, ICG lymphography, and the incidence of complications. And so we planned this procedure in about 106 patients. We were able to accomplish it 98% of the time. And I think the reason we were successful in this is because we really spent time trying to figure out how we can completely visualize, the lymphatics in the arm. Sometimes lymphatics are just unavailable, and sometimes the veins are unavailable, and this happens. But moreover, we can, most of the time we can find what we need in terms of anatomy. Oftentimes we can preserve in continuity lymphatics. Usually we can go and find anywhere from 1 or 2 per case. Usually they run along the axillary vein. And we find anywhere from 1 to 5 transected lymphatics with a mean of about 2. Typically, we perform a mean of 1.6. Obviously, we try to do more, and over time, we are doing more and more LV bypasses per axilla, which comes, I think, with just a learning curve. And patency is confirmed in every case. 5 out of these 106 patients did develop lymphedema, so that translates into a 4.5% overall lymphedema rate. All these patients had post-mastectomy radiation therapy, some of whom had additional complications like infected seromas or grade 3 radiation dermatitis. All of them had chemotherapy. So this is sort of the overall results over the course of the study period. Again, 4.5% of patients developed lymphedema. Whereas in our control group, 14% of patients over the same duration develop lymphedema. In patients who have a full 2-year follow-up, which is one of the things that's a little more unique here, 13% of patients with a 2-year follow-up develop lymphedema. So that's an increase. But this compares with 29% of patients in the control group who develop lymphedema. And this is all with respect to the fact that more patients actually had post-mastectomy radiation in the study group than in the control group, and more lymph nodes have been removed in patients in the study group as well. So, we have learned from what we've been doing that really refining this lymphatic reconstruction through different dye techniques and performing the axillary lymph node dissection a little more strategically and delicately really increases the ability to do this well. And you really have to have buy-in from your breast surgery team. We're, again, always really able, in the vast majority of cases, 96% able to demonstrate patency. Those that don't have patency demonstrated, that is basically a function of lack of valvular competence or venous problem with venous back pressure. Again, in our experience, we have a favorable outcome with ILR. Obviously, long-term follow-up is needed and is ongoing. We're hoping that we could develop a lymphedema rate that's equivalent to that of sentinel lymph node biopsy. Our overall results are in line with that, and that's similar to some other reports, similar to Brocardo's 4-year report as well. It's difficult to measure patency, long-term patency of the LV bypass, and that's a limitation. Our resolution of ICG lymphography, the depth of penetration of near-infrared cameras is only so deep, and in an axilla in a larger person, it's hard to see this anastomosis, but it can be done, and that's what you actually see in these pictures here. The top picture represents a left axilla. And this is in a patient who had stage 2A breast cancer. This was a set of photos was taken about 18 months after their initial surgery, which included axillary lymphadenectomy and lymphatic venous bypass ×3. And the patient had post-mastectomy radiation, and with the follow-up lymphography, we're able to really clearly demonstrate lymphatic collectors going directly into the axilla. And presumably through our anastomosis. So I think what's really important about this, about starting to do this, is to have a coordinated interdisciplinary approach. And I know I'm running short on time, so I'll kind of get this wrapped up. Really having a buy-in from your breast surgical colleagues in terms of modifying their technique a little bit, having a collaborative effort in terms of surveillance and postoperative care with your therapy team, making sure that your medical and radiation oncologist and the patient and the folks who follow up these patients in the long term, medical breast people, whoever does your survivorship, is attuned to lymphedema That way you can really, you can kind of nip it in the bud if it occurs, and really prevent progression. And we've kind of worked with our teams to develop some clinical pathways in order to try to figure out systematic ways to incorporate this, in our institution. There are some barriers. There can be some, difficulty with surgical oncology buy-in, but I think you can convince them when they see some of this early data that it's worthwhile doing. It does take some additional time. There's no doubt about it. But we've kind of looked at our data, and over the course of the study period, with decreasing time has come increasing number of anastomoses, which translates into increased lymphatic flow. So it's not really hard to demonstrate the value of this, I think, to all of the people who touch these patients who develop lymphedema along the cancer care continuum. We have a particular postoperative surveillance program where our patients get automatically referred to our therapy team. If lymphatic dysfunction occurs, then they get referred back to us for consideration and workup for potential lymphatic reconstructive surgery. So, in finality, I think that lymphatic reconstruction in the immediate setting is effective. I think that we've demonstrated that our breast cancer-related lymphedema rates are lower than in folks who don't get this immediate lymphatic reconstruction, but there are clearly opportunities that exist to really look at how different aspects of cancer care contribute to lymphedema development in these patients. And it really, multidisciplinary collaboration is essential to maximize clinical and health-related quality of life outcomes. And with that, I want to thank Christine, and I want to thank the PSRC for inviting me, and I look forward to everyone else's presentation. Thank you.
Beautiful, beautiful work. Thank you so much for sharing that. And I'm sure there'll be a lot of discussion at the end of the talks about what you're doing and where to move forward from there. All right, I'm gonna. Can you stop screen sharing?
Yeah.
For some reason it's not letting me share the screen. April, can you help with that?
Dr. Schwartz, you need to.
I'm sorry.
There you go.
I stopped. I think we're good.
Okay.
Yep, you're good.
Sorry about that.
You should now be able to, Dr. Rodi.
All right, let me try. You know what? I think it's because I went in with a different Zoom. Do you want me to log out and come back in, or?
Let me check one more. Okay, try now.
Okay. Yep.
You're good?
Yep. Go ahead, Katie, if you want to say something.
I'm going to just introduce our host, Dr. Christine Rodi. She is a full professor of surgery at Columbia University Medical Center. She is the vice chair in the Department of Surgery for Faculty Development and Diversity and the chief of microsurgery at Columbia. Her research interests are also health services related to the use of randomized controlled trials in plastic surgery, and she's chair of the ASPS PSF Clinical Research Committee. So we're excited to hear her talk.
Thank you. So I'm going to switch gears a little bit, and I just wanted to talk some about what we've all been going through over these last few months. And unfortunately, New York got to be one of the first places in the US to deal with COVID. And so I just wanted to share a little bit of our experience. And I'm sure that a lot of what I'm going to talk about has been played out in other parts of the country as well. So some disclosures that have nothing to do with this talk. So as you all know, COVID is a large family of viruses, some of which cause the common cold, and SARS-CoV-2 is what causes coronavirus 2019. And it was first detected in Wuhan in late 2019, and it probably spread to humans from bats, and it's now grown into a pandemic. The first laboratory confirmed case in the US was reported to the CDC in the end of January. And the first case in New York City was announced in March 1st. And at that time, there were already 88 confirmed cases and 6 deaths in the US. And you'll recall that the Diamond Princess was a place where there were multiple people infected with COVID, and then there were multiple deaths at nursing homes in Washington. So these were the things that were already around when the first coronavirus case was announced in New York City. So there were preparations underway already for a hospital surge at that point. So at Columbia, again, this is, I'm sure, the experience that has played out throughout the country. It was a time when we were talking about resource conservation, shortages of PPE. Our ORs were converted into ICUs, and anesthesia machines that are usually used for operations had to be converted to be more for chronic ventilation of patients. At Columbia, there was development of the surgical SWAT team, which our residents have published about, the Surgical Workforce Access Team. And it was a team of surgical residents and attendings who would be available anytime, day or night, anywhere in the hospital when there needed to be some kind of bedside procedure, lines, trachs, chest tubes, that kind of thing, and in a way that would help alleviate some of the pressures on the ER and the ICUs. And obviously there were shortages of ventilators. There was a lot of discussion of rationing ECMO and how to deal with shortages of CVVH machines. At the same time, there were opportunities for some contemplation and hopefully some grace under fire during this time. If you weren't aware already, our chairman, Dr. Craig Smith, would write a daily update about what we were going through as a hospital and what we were going through as a department. And there was often a lot of encouragement as well as stark reality in his writing. And it became something where it got into the public eye. And so this was a Washington Post article about him being the most powerful writer in the pandemic. We also put on some concerts to perform for some of the patients and for the staff. And there's me and a clip from NBC where we would put on these concerts, again, for just some welcome distraction during a really difficult time. So what about cancer care during this time? It certainly is the kind of thing that you don't want to put off, but at the same time, probably not the most emergent thing going on when you're dealing with an infectious pandemic. So we recently looked back on the time period from March 17th to June 9th, with June 9th being the first phase of NYC reopening and March 17th kind of being the time period when things pretty much shut down for us. And during this time, only emergency surgeries could be done, and these needed to be approved by a central committee. And obviously any case that could be safely postponed was. And in particular, any COVID positive patients had their surgeries postponed. And during this time, there was more and more literature, including coming out of Columbia, showing a significantly increased mortality and morbidity rate in patients who were COVID positive who then underwent surgery. So in particular, anyone who was COVID positive had their surgery postponed. So we compared breast cancer patients who had surgery during this acute COVID period with patients during the same time frame in 2019. And we looked at hospital admissions, demographics, comorbidities, and collected them prospectively for our COVID-19 group. Again, this group is the ones who were operated on during COVID, but it doesn't mean that they had COVID. And then we looked at it retrospectively for the matched group. So we only operated on 48 patients compared to 148 during that same time period. And more of the patients in this COVID group had undergone neoadjuvant therapy, which makes sense because those were patients who we really did want to get into surgery in a timely fashion after they completed neoadjuvant to really be able to get the benefits of neoadjuvant. Otherwise, the groups were fairly similar in demographics and the primary oncologic procedures performed. And the decision was made, and as was the recommendation from national and local societies, that if someone needed a mastectomy, they would be permitted to undergo immediate expander implant-based reconstruction, but no autologous reconstruction. So if someone did have a mastectomy, they would be able to get, if they wanted, a tissue expander or direct to implant And there were some cases when patients were allowed to have an oncoplastic reduction or mastectomy at the time of a partial mastectomy. So again, there were no autologous reconstructions done, and for patients who wanted them, they went in understanding that they would have pre-packed expanders placed, and then we would do the deep flaps later. So among the patients who had lumpectomies, pretty much there were no differences in the rate of complications or readmission. And interestingly and importantly, none of the patients developed COVID from coming into the hospital and having surgery. And the only significant difference was that the number of in-person follow-up appointments within 30 days was significantly decreased in the COVID group. Sorry about that label on there, compared with the prior year non-COVID group. And then for mastectomies, again, for the most part, there weren't significant differences between the two groups. And importantly, there was a significant difference in patients that were able to have ambulatory surgery for their mastectomy or mastectomy and reconstruction. And then we also found, although it wasn't statistically significant, that there was a decrease in the amount of visiting nurse services used. And once again, none of the mastectomy patients developed a COVID infection from having come to the hospital to have surgery. And as a side note, this was looked at in the cardiac literature as well, and none of the cardiac patients who were sitting in the ICUs developed COVID while they were in the hospital. So in terms of resource utilization, we found that our mastectomy patients had fewer ER visits, fewer readmissions, a shorter hospital length of stay, less use of VNS, and fewer in-person follow-up appointments. And all of this makes sense in a time when people are trying to stay away from the hospital, they're trying to minimize their time in the hospital, and they're also trying to minimize their exposure to other people, such as visiting nurses or going back to their doctors. And so lessons learned from all of this is that with motivated patients and surgeons, ambulatory mastectomy reconstruction can be safely performed. And I think a big part of it is that the surgeons are willing to do this, and it's a matter of convincing patients that it's safe for them to do this. And once there was this external motivator, they were willing to leave the hospital the same day and did not have any increased risk of complications by deciding to do that. Also, I'm sure all of us have seen during this time that telehealth is an effective tool in some cases for patient visits, and I have even done these complex reconstruction discussions over telehealth, but as well with post-operative visits. However, there are ongoing challenges for us because there still are OR limitations and there's still the desire to conserve some in case there's a second wave. Then we're still trying to deal with a backlog of patients, especially the ones that we promised deep flaps to before that we need to find time to do now, while we also need to be doing our new patients that are coming in and want flaps. Also, there are telemedicine accommodations that expire in October, and it'll be interesting to see if we continue to embrace telemedicine when there become geographic restrictions as well as reimbursement restrictions. So these are some of the ongoing challenges as we deal with COVID. So I just want to thank the group of breast surgeons and plastic surgeons that I work with as we continue to deal with COVID across the country. Thank you. Okay, let me just see. So again, we'll have time for questions at the end, and I'm now going to introduce Dr. Antony, who I'm very glad was able to join us just out of the OR. So thank you so much for joining us. So Dr. Antony is a professor of surgery, and she's vice chair in the department and chief of breast reconstruction at Rush University Medical Center. She did her training in plastic surgery at Stanford and then did microsurgery at Memorial, as well as having a master MPH from the Harvard School of Public Health and an executive MBA from Northwestern Kellogg School of Management. So she's someone with a lot of expertise and a lot of degrees. So Dr. Antony, thank you so much for being here to speak with us.
Hi there. Yes, I just got out of the operating room, so give me a second to get this sort of figured out. And Can you hear me, Christine? Okay. And then let me share screen, I think. And PowerPoint. Into.
And while she's loading that up, again, please share your questions at the end via chat, or just simply speak up when we're done with this talk.
Okay. Great. Well, thanks for having me here tonight, Christine, and it's a pleasure to join all of you. I am going to talk a little bit about, a technique that I think a lot of patients in Chicago really desire, which I know that Christine and Graham also have lots of experience with. I certainly echo all of Christine's sentiments. COVID has certainly been interesting. I haven't really been able to offer this for some time because of the effects of our sort of change in model, in the sense that we were deliberately trying to do tissue expanders and quicker procedures in terms of only ones that were warranted, delaying some of the surgery. So now we also similarly have sort of a rush of patients and trying to deal with the backlog. So we're actually booking out till February and trying to accommodate patients and just adding ORDs wherever I can to be able to address both the backlog of patients as well as the sort of continued new set of patients. So bear with me, it's been a pretty brutal couple of weeks. So hopefully, everything goes well here. These are my disclosures. It's interesting because if you look at Chicago, this was not too long ago where we were just celebrating the Chicago Blackhawks victory. And, this is sort of what I think of when I think of Chicago. And then this is for me on a walk the other day. And it's like bridges up, trucks, barricading roads. Sometimes it takes an hour to get home. And every night we're not sure. I'm not always sure if I'll make it all the way there. And it's more like this, it's somewhat empty and deserted at times. And certainly we're all sort of using precautions. So it's just been a very interesting year. And I think all of you can kind of relate to each of you in your own area. Certainly New York was hit hard. Chicago has been hit by multiple onslaughts of different issues related to not just the pandemic, but, social uprising and other issues that have caused a lot of distress for people. So, there's been a somewhat of an egress of people actually from the city as well. That being said, it's been quite busy from the surgical side in the hospital. So I'm going to shift gears a little and just try to add a little levity to this somewhat at times not so easy time, and talk about breasts and the ideal beautiful breast over time. So I actually studied art in Italy. I actually am a trained painter and sculptor. And so I like to think about the breast in terms of, the decades. And I think, this moment in time has sort of made me also reflect on, how things change over the centuries, and, that we're sort of revisiting a pandemic that occurred about 100 years ago. So it's just been sort of on my mind. Anyway, when we think about the beautiful breast, we think about Botticelli and Tizian, and these are sort of classic silhouettes that were identified as beautiful. And then we go into Cezanne, and he really liked sort of round fruit, and so his breasts sort of look a little bit more globular. And then Matisse, who maybe liked a little bit more of a pointy breast. And then we think about Picasso, who certainly had his own perspective. I think that even in that lower image, you can discern where the breasts are, and I think there's sort of some characteristic features that help our eye understand where the breast is. So this is actually me when we could travel, and I like to look at pictures at times when we could actually travel and go places, where I'm in Italy actually. And this is the sculptor teaching a course, and you might recognize Basil Sharif in the background. And so we were actually doing a sculpture class, 2-day anatomy class, and I like to think that one day we'll get back to these times where we can see each other and actually enjoy some of our passions. And so, interestingly, breast cancer has a special place in my life, not only in the lives of my patients, but also just before the pandemic, my mother was diagnosed with breast cancer, and she asked me to be a reconstructive surgeon. And so I think that, you know, we'll see so many things about our family, our lives, our work kind of joined together. So, you know, I'm just grateful that her care was essentially completed prior to the, you know, the true pandemic hitting within a month or two. So we'll talk about a little bit about the beautiful breast, and you know, as I mentioned, it's oftentimes influenced by time. In older times, it was paintings and drawings, and you know, in modern times, it'll be perhaps Instagram. And we shouldn't ever forget to listen to what the patient wants, to interpret what she desires, and to try to create or recreate a breast she finds desirable. It's certainly been challenging in the pandemic. We're still even dealing with patients who may have only gotten one side prophylactically, depending on the breast surgeon, you know, denied the prophylactic side, and now we're trying to sort through different algorithms as they've had one side with, you know, the cancer addressed and the prophylactic side yet to be addressed. So certainly, you know, there's just a lot of contextualization here by anything I discussed tonight, just to be mindful that, of course, I myself am also sensitive to the things that we're dealing with. But tonight I'm going to just talk about alloplastic breast reconstruction, you know, whether to go above or below the muscle, and, you know, prepectoral breast reconstruction really being above the muscle and can be done with a variety of different biologic or synthetic mesh materials. You know, I think that a lot of us feel strongly about prepectoral breast reconstruction. I also use it for my microsurgical cases as a staged method, particularly during the height of the pandemic with putting tissue expanders in, and similar to Christine, we're finding challenges trying to find time to handle all of the deep flaps as well. But, you know, I think that it just sort of has to work itself out. Anyway, the idea for prepectoral breast reconstruction and direct to implant is that there's a shortened recovery time, improved mobility, and we eliminate that muscle animation deformity. And I really believe that it transmits a better shape and form and allows the implant to really engender a nicer and improved shape through the envelope. And I think obviously the psychological and social benefits that mimic augmentation. I have had more and more requests now for DTI as the effects of the pandemic, as more and more patients would like to avoid as many trips to the hospital, see if they can actually get surgery done in one stage so that they can kind of move on with their lives, as many of them actually have plans to move to, it seems like Florida, the Carolinas, and Texas are very popular these days. And I hear that actually from several of my patients. So the reasons for prepectoral breast reconstruction are namely, you know, these types of animation deformities that we see. So when we look at a static 2D image, you know, I think we lose a component of the actual construct and actual life for the patient, whether moving or playing tennis or running or performing their some normal activities. And so it's important to have that understanding that all breast reconstruction may not be exactly the same experience for the patient. Certainly there's a historical precedent dating back to the 70s, but was wildly unsuccessful, mainly due to the inability to really stabilize the device and a lot of capsular contracture and bottoming out. That sort of led to the advent of some of our more conservative positioning of the implants behind the muscle. And then, you know, certainly there's been biologic meshes that have helped, and as well as skin and tissue envelope changes and preservation. So I think it's this amalgam of advancements that have allowed us to evolve breast reconstruction. And, you know, there's some nice data presented in 2017 describing, you know, indications for when we might consider using prepectoral breast reconstruction and when we might not. And it can certainly be done with tissue expanders or DTI, though I'm going to sort of focus on DTI. I do also do prepectoral tissue expanders with a slightly different technique that I'll describe tonight. This is some data that I've actually presented back in 2017 and then subsequently published this past year. You know, I think in concept, it really is no different than some of the subpectoral procedures. Just the key difference is the position of the device. For me, it encompasses about 50% of my practice, and it's done preferentially in the prepectoral space. I like to use an overlay technique using ADM, and I think it really amalgamates the benefits of direct to implant and prepectoral breast reconstruction placement. But of course, there's a potential for magnified incidence of complications, and many of us are aware of those that are present from historical references for prepectoral as well as from DTI. And so I think it presents unique technical challenges. I'm going to present some of my data and some newer data as well. This is some older data that essentially where we looked at breast reconstructions and divided them into different cohorts. And then we also looked at direct to implant breast reconstruction and dividing those into cohorts, and we restricted these to a year or more follow-up. You can see that the tissue expander and direct to implant cohorts are represented here, and then the dual plane and prepectoral direct to implant cohorts represented here. And you can see their demographics are essentially the same with no significant differences, similarly for their indications and adjuvant treatments. And then, you know, we looked at some of their reoperation rates as well as complication rates, and we really didn't see a significant difference. In fact, we actually saw a lower incidence of complications, though not really significantly different. The one thing that is interesting that I think bears some reflection, and this you know, is similar to what I've seen in my own practice, is that the prepectoral breast reconstructions, when we did a blinded aesthetic score with evaluators not being directly involved in their care, but having had that either from medical oncology or radiology, you know, our colleagues ranking them, we found that they ranked the prepectoral breast reconstructions as having a higher aesthetic score with a lack of implant ripping and visibility, which I think goes against sort of perhaps what feels intuitive, that the implant would be more visible. There we go. And so we did not see a degradation of aesthetic results or higher complications. We saw that you know, animation deformity was completely eliminated from the prepectoral cohort. This is some newer data. This actually was accepted to the ASPS meeting where we actually did a multi-center retrospective study with 4 different centers, including ourselves. And we actually found lower health resource utilization with the prepectoral breast reconstruction, as well as we found some benefits in terms of postoperative pain and analgesia. So it's kind of exciting to see that what we also believe is also being manifested in this larger center study. Because it is being presented at the ASPS meeting, I'll sort of keep it abbreviated. I'm fortunate to be able to be senior author on this, but certainly many authors contributed to this work, and I think it's really exciting data that will be coming soon. So now I'll just show lots of photos in typical plastic surgeon fashion, just kind of show you what I think is exciting about prepectoral breast reconstruction, and these are all direct to implants. And so these are all single stage with no revision. So this will show pre-op, 6 weeks and 1 year, again with oblique views. This is a patient actually who was an FBI agent, and she had had previous radiation. And so, you know, I figured she wanted to be able to shoot her gun straight. We should make sure we try to accommodate her. And so again, pre-op, 6 weeks and a year with lateral views. We actually have 2 and 3 and 4 year data on many of these patients. This is again pre-op, 6 weeks and a year. This patient actually has referred so many patients to me, I think, because some of the things that I like us to reflect on is some of the things that we do with our studies don't always distinguish between implant-based reconstruction. We distinguish between tissue expanders and DTI, but we don't always distinguish between prepectoral and retropectoral. And so, you know, as we engage in future studies, especially larger trials, I think it's important to perhaps evaluate these cohorts of patients slightly differently, and because we tend to look at deep flaps versus tissue expanders or deep flaps versus implants, but I don't think we always discern between where the position of the device is, and I think that actually does make somewhat of a difference. Again, oblique views, pre-op 6 weeks and 1 year, direct implant single stage or direct implant breast reconstruction. Again, oblique views. This is a unilateral breast reconstruction on just the left side with her natural breast on the right side. Oblique views. I think that we've also pushed the envelope of what we can do for some of these patients where previously we may not have considered, is they have somewhat of a ptotic envelope. If they're willing to accept a slightly larger implant, we can actually mimic similar to what an augmentation does with superior and rotation of the nipple to adjust for those ptotic features of the breast. Again, oblique views. We can add upper pole fullness and really rebuild the breast into a breast that maybe feels more ideal for the patient. This is a unilateral breast reconstruction in a younger patient, unilateral reconstruction. And then I did have a small video that if anyone's interested in this technique, I will just play if time allows. It's on just prepectoral, it's about a minute. And so you may see some things highlighted here. Again, dynamic deformity really being what most of the patients come to me describing. And I have a lot of patients who now fly in to see me for this technique. And I do quite a few conversions. I'm actually amalgamating my data on conversions and hope to show that at some point. So, you know, I always like to assess the tissue perfusion. We do a full mastectomy as demonstrated. And so you can assess tissue perfusion both for nipple sparing or skin sparing. However, you know, your breast surgeon feels is safest. I put a sizer in. I use saline just because it's cost effective, and then I sort of just mark out the pocket. I like to do anterior tenting if I'm using a direct implant, and that's just the pocket marked out. I do a back table sizing of the biologic. You can use, there's lots of things that's been described, but I find that ADM works well in my hands, and so I tend to continue to use that. I then anchor it into the pocket. Superiorly, I just use interrupteds, and then where there's any kind of area where I feel that we need to anchor or form stability, I just reinforce with PDS. It's just then placed with an insertion sleeve. I think this is the most important part, is just at the end of the operation is casting the skin envelope such that you position the nipples and allow that tissue to mold. And you can really remold the breast into the shape that you would like. And then this is the ultimate benefit, I think, for the patient. And then just, you know, just the nice thing about it is it's just a very nice natural looking breast. And, you know, I think these patients really feel that they, and I'm doing a lot of video calls where I'm seeing breasts now on my telehealth appointments where I get to evaluate how they're doing. And again, you know, I think this is just sort of the difference that I think is very visible. So, you know, of course, you have to have considerations about your surgeon being reliable, your axis incision, ptosis is a consideration, and then certainly what kind of implants. These days, of course, we use just all really round implants, but projection can be altered. And then, of course, careful selection in the radiated patient. Thanks.
Thank you, Dr. Antony. Beautiful results and a great demonstration of the changes in technique over time. So I want to open it up to anyone who has questions. Please put them in the chat, or if you want to just go ahead and chime in with questions, then we'll do that. And while we're waiting for some questions, I think who will I start with? I'll start with Anu, if I may. You do mention at the end relationship with breast surgeons, and how much discussion is there with the breast surgeon when you tell them, okay, I'm going to be doing pre-pectoral DTI or pre-pectoral tissue expansion, and I can tell you some of the issues that I sometimes have is that some of my breast surgeons love to take out everything to the clavicle because that's where the breast ends, and those patients require so much fat grafting. And so I'm just wondering about the conversations that you have with the breast surgeons now that we're switching over to pre-pec.
Yeah, I think that it is a delicate balance. You know, ultimately, I always want to reassure them that we oncologically want to be appropriate, and we're all on the same side. You know, it's required some careful navigating with all of our breast surgeons in making sure they understand. But I think that once they see the results of the prepectoral breast reconstructions, they become sort of your cheerleaders, and it's interesting because they somewhat compete with one another now. I feel like um, to make sure that they deliver these beautiful flaps for us. I do understand that sometimes, especially in that superior area, there can be times where it is incredibly thin. For me, as long as it's perfusing fine, I'm comfortable proceeding. But certainly, I always warn patients, if you're doing direct to implant, the tissue expander is always a possibility, and I certainly have no problem backing it up or even going retropec if I need to. So the patients are very well informed, and I think that you just have to navigate it as best you can. I'm fortunate that one of my breast surgeons I've known since fellowship at she did her fellowship at Stanford when I was a chief resident. And so I think having like a decade-long friendship with someone, we're very honest with one another. She's very quick to let me know when I'm taking too long. And I'm in her room, and I'm very quick to tell her when the flaps are a topographic, mess. And so I think that really helps having that kind of cordial relationship, So I don't know if others on the panel have had similar experiences, but I really do think you have to develop and cultivate a very close relationship with your breast surgeons in order to be able to execute some of these techniques in a proficient way, in an easy way where you don't feel stressed out.
Mm-hmm. Yeah, that's a great point. And it's also a great point you make about making sure that patients know that even if you go in thinking that your plan is, for example, a prepectoral DTI, that it may be that you need to do a tissue expander, or even that you may need to go retropectoral, and that there are kind of backups that you may need to go to. Graham, I could talk to you for hours about your talk. Or did you want to say something?
Well, no, I wanted to also, hey Anu, how are you? Good to see you.
Nice
I wanted to, awesome talk. I actually wanted to sort of follow up a little bit on, Christine's question, because I feel like I can't reliably solve this problem. As we've moved to, round implants, especially whether it's DTI or we're using tissue expanders, it is rare that I find an instance where it's truly a single stage surgery. Obviously not in tissue expanders, but when doing a DTI, a pre-pec, I find that I almost always need to do fat grafting. Do you think that's a function? Is there a technique change that I can use to mitigate that, or is it you think it's the breast surgeon? Is the way I inset the alloderm, or what are the strategies to get better at that?
Yeah, I'm happy to share a few pearls that I think help. So one, I think that this is going to feel counterintuitive, but if you use the extra high profile implants, it actually compensates for the thinness in the upper pole. And so what you're worried about is actually, the intuition would tell you don't use that because it's going to look even more projecting. But actually that extra volume helps compensate for the reduction in the amount of tissue that's available. The other thing that I do is I put the pockets very tight and almost like bulging slightly superiorly, meaning that I intentionally narrow the width of the pocket using the ADM compared to the base width of the implant. And as the tissue relaxes, or the ADM relaxes and softens, it drops into a perfect position. But you almost have to anticipate the drop, just like a breast dog. It's sort of going to settle. Same thing, the ADM is going to stretch. And so I find that also helps. If somebody's incredibly thin and you just think, what, there's just going to be a lot. I've still done DTIs on those patients with these two main techniques that I feel that really helps the most. you can always do a tissue expander and say, I'm going to be coming back anyway. And I have no problem fat grafting patients. And when I fat graft, I'm very aggressive. I've found that you can compensate for some of the volume loss using the implant and then the technique. And that's just my own experience. And so I think that helps. Sometimes you'll still have a patient where you think you knocked it out of the park and there's still like a little area that bothers them when they move a certain way or something. And then you can just justify whether you want to go back or not. I tend to be pretty generous and say, if you can see it and I can see it, then I'm happy to do it for you. But sometimes they're pretty small, tiny areas. And so.
And can I ask one more question for you or anyone else on the panel? You know, if you're doing a prepectoral tissue expander, right, which is already shaped, so you have maybe the advantage of already shaping your pocket. Do you do anything to capsulotomize the superior aspect of your alloderm? You cut through your alloderm superiorly to kind of let things smooth out, or do you keep it and do you just fat graft that shelf if you get it? That makes sense.
I'm happy to answer, but I'm happy to open it to the panel. I always do a capsulotomy only because if you don't, you have to put so much fat graft to redrape that skin properly, and you end up having, it's just a lot more work. So I still fat graft it, but I always perform a capsulotomy. And even if it's just a minimal and just to break right through the capsule, because it just redrapes the skin so you don't get that shelf. And that's what works for me. At first I wasn't doing that, and I found that I had to work really hard to like kind of adjust for that sort of contour that's very round in the upper pole with an expander. Now that I do capsulotomies almost routinely, I find that it's not as much fat grafting, or you don't really even need it sometimes.
Yeah, and I'm the same. Yeah, I always do that upper pole capsulotomy for this same exact reasons.
Me too. I've had when I've been a little bit more aggressive, even if I've stayed really, really close to the muscle, I've had a couple of instances where I feel like compared to, even if I'm using a highly cohesive, extra projecting implant, I feel like I've increased the amount of rippling that I see, compared to other folks where I'm a little bit less aggressive with the capsule. I don't know, maybe it's just the skin envelope, at baseline, or maybe I'm choosing, the wrong size implant. I don't know, but I haven't quite figured it out.
So are there any other questions or comments from the participants? For Graham, I do want to point out that I think that you are very meticulous in your technique, and then to make sure that you're getting flow. And I think that the use of an LV bypass for prevention so much is technique dependent. And I'm wondering if you're aware of this study that the breast surgeons are doing, where I don't know how to say this. They're saying that they're trying to prevent lymphedema by doing it themselves, by putting some fat near the lymphatics, and they're testing to see whether that will work. And my concern for that is that if you have people who aren't really doing it in the way that you are, where you're doing microsurgery and super microsurgery and really making sure that you have patency, then you're actually doing a disservice, because if you don't find any difference, then there's more of a chance that people abandon a technique. Do you have any thoughts on that, or?
I do. There's the technique of doing this LV bypass, and I think one of the major trials, or what's it called, like the advanced trial, they have the reverse lymphatic mapping arm, and then you can add in, this sort of LV bypass approach too. And like you said, I think that for some people, they're just kind of describing putting some lymphatics next to other lymphatics and tacking everything together with like a 6-O-proline. And then there's this other technique, this S-lympha, simplified lympha. I guess our technique is like the
Complex lympha.
Yeah, exactly. The C-lympha, the complicated lympha, right? So, but my take on that is that the way that the breast surgeons talk about this, or the person who's really responsible, I mean, I think, and they should be giving credit, Dr. Klimberg and her, all of her data you know, when she describes putting lymphatics together, it's a, you know, it's a non-microsurgical technique. But, you know, if you look actually at the references, it's based on, she actually cites a rodent study. So I think if you put, you know, if you've done any kind of small animal work, you know that like if you cut the lymphatics and you could put them like, you know, 5 inches away and you would still get regeneration of lymphatics. So I think that your point is well taken. I don't think that all of these types of procedures are created equal. And unless you're really proving patency, you know, or, you know, we evolve into a way where we can actually, you know, have the resolution, depth of penetration to see if there is actually continuity of lymphatics or neo-lymphangiogenesis, I don't think you can quite make a claim that just putting things close together is working.
Thank you. So I realize that it's a late hour, and I really appreciate everyone who's been on with us. Does anyone have any final questions or comments? All right, then once again, I want to thank Jason with Allergan Aesthetics for sponsoring these talks. I want to thank April for arranging everything, and remind everyone that we have one more. We have our last session on Thursday where we're going to have our second group of best breast abstracts that were accepted to PSRC. And then after that, we'll have a mentorship session with some of our faculty. And I really encourage you to join us on Thursday as well. So everyone have a good night and stay safe and be well.
Good night.
Right.